I just want to start this discussion really by clarifying what I mean when I say mission. And I think so many people use the word and we use it inconsistently. When I'm talking about mission, I'm really talking about the purpose of the organisation, or really the reason why we exist. And I think there's two aspects of this that are interesting to explore. The first is the services that we choose to provide, and the second is the style or the type of organisation that we try to be. And I just want to unfold these two ideas for you. It's interesting when we talk about who we choose to serve, because in fact I'm from the private sector, and lots of people ask, what's the Catholic system doing in the private sector? And I think that this is a valid question. If we provide services that are identical to those offered by the for-profit sector, then we've got a lot of explaining to do. I think the differences should be clear in the services that we choose to provide, that we're not just always chasing the dollar, but we're trying to provide the services that our communities require. And we do have to be profitable, but we don't just choose profitable services. And by this I mean that it's an excuse for inefficiency, because certainly it's not. I mean that we choose services that we know will be poor payers if we know that those are the services that our communities require. And just on that note, it's not just about providing services that are poor payers, but it's also about trying to make decisions that reflect the needs of our patients. So if it means that a patient gets sent home before we hit the trim point for a higher rebate, then that's what we should do, because that's what the patient requires. And if it means that we have to cover a greater gap in order to price our services so that people can access them, then that's also what we should do. So for me, in the private system, I don't have a problem with the fact that we're in Catholic healthcare. Another question that the community asks is, well, what are we doing in the public system? And although for us it's clear that it's much more closely aligned with a preferential option for the poor, people question about the fact that Catholic hospitals can't provide all services that are required by a community. In actual fact, very few hospitals are able to provide all services that are offered by the community. So I don't think that this limitation is a reason for us not to be in public health care. I think another distinguishing feature of Catholic healthcare is the style of service that we aspire to provide. And I think this is really based on the ethical principle of respect for life, and that plays out in very nuanced ways in our organisation. I think it's beautifully described in the Code of Ethical Standards for Catholic Health and Aged Care. And one of the things that attracts me the most about that document, I think, is the way it describes the relationship that should develop between the patient or resident, the doctor, and the other members of the healthcare team, the family. And it describes this relation of one of trusting collaboration. I think there are a couple of interesting elements in that. What underpins trust? It's a very difficult relationship to develop when you've got a professional on one hand and a patient on the other. It's a very unequal relationship. But if we really want to develop this trusting collaboration, then it requires a whole different way of engaging with each other. The other aspect of the trusting collaboration that we talk about trying to develop between the patient or resident and the healthcare team is the notion that we're working for the authentic good of the patient. And again, I think this is a very deep concept that goes way beyond a professional relationship that you may try to establish in the public healthcare sector in general, for example. Another element of respect for life that plays out, I think, in the Catholic healthcare sector is in holistic care. This is, again, a very deep concept, I think. When patients come into an acute care facility, it's often the first time that they really feel that their life is threatened. They have a sense of their own mortality. And it's in times like these that the deep questions in people come to the fore. In everyday life, it's easy to put these questions off. We're too busy doing things to really explore these questions. But in the healthcare environment, I think it's times like this that these questions come to the fore. Another element of respect for life is recognising that life is temporary and will naturally come to an end. So we don't seek to extend life unnaturally. When we realise that life is coming to an end, we have a real role to play with the patient and with the family in making that part of their life the best possible experience for them. So I think in all of these ways, respect for life plays out in the Catholic healthcare setting in a very nuanced way. So based on this sort of understanding of our mission in Catholic healthcare, I now really want to come to the central theme of this podcast, which is about the must-haves to have mission as the senior partner. On paper, the board is responsible for mission, but in my experience, it's really the CEO that is the most influential person in mission being achieved. And that's partly because the organisation is filtered to the board through the CEO. So if you don't have a CEO who has a disposition to understand and value the distinctiveness of Catholic healthcare, then in fact there won't be any mission. Mission won't have the upper hand in this relationship. I'm not saying that the CEO is responsible alone for achievement of the mission. The CEO certainly has influence over the sorts of services that we would provide, but single-handedly they can't affect the whole culture of the organisation. So the leadership team is also important in mission being achieved. Firstly, I think there needs to be a shared vision of what mission means, what are the goals of mission in this particular strategic period, and a program of work to achieve that. So for a leadership team to achieve that sort of vision, I think it requires trust and openness and collaboration and all of the strengths of the leadership team being put to this work, that we work together, learning from each other to create this shared vision. I think if we really want to live our mission, then it's reflected in this notion of organisational integrity, which means that we're all aligned really to try to help employees do the right thing for the right reason. If you think about it, every aspect of the way the organisation works has an ethical dimension. There's an ethical dimension in employment, there's an ethical dimension in budgeting, in strategic planning, in every activity that we undertake, as well as the sort of care that we try to provide to our patients. So we need to make sure that we have a culture that's going to really support people being able to do the right thing for the right reason. I think the board has a really key role in mission governance as well, despite the fact that I said really, the CEO is the critical person. The board does have responsibility, and I think it's able to enact its responsibility through mission governance. We talk about clinical governance in organisations, ensuring that we provide safe and effective care. And we talk about corporate governance to ensure that we have legal compliance. But I think this has to be overlaid by this concept of mission governance. It's not really good enough just to give safe and effective care, but there's a quality of care that we're aspiring to provide in a Catholic institution. And it's not just good enough to be legally compliant, but we need to make sure that our actions are ethical as well. So I think the board has a role in structuring a suite of measures so it can monitor how well we're doing in these dimensions. The board has to have some measures to ensure that there's a pervasiveness of this culture that we're talking about, that our values are really expressed in the actions of everyone in the organisation. I think Catholic organisations also have a responsibility to engage with the community. If we're to provide the services that our communities need, we have to have some way of being a good community partner, and I think there are measures around this that the board need to take on. I think the other dimension is that we receive benefit from the taxpayers in the community to provide these services. So we have to be quite clear in the way in which we're delivering benefit back to the community. So I think that there are areas here that we should be quite clear in communicating. How we subsidise healthcare services, how we reach out to provide healthcare to underserved groups, how we engage our staff in doing this, how we engage with other social agencies to provide for the needs of refugees, new immigrants, Aboriginal health. There are all of these dimensions, I think, that the board need to ensure that they have good measures around, because if they don't have measures, the organisation won't prioritise those things. I spoke earlier about the style of service that we aspire to give, and I talked about the importance of trying to meet the spiritual and emotional needs of patients when they're in our facilities. I think there's this other must-have in ensuring that mission's a senior partner, and that's around our pastoral care resources. In a lot of organisations, pastoral care is seen to be the soft option, but I think if we're really to ensure that our mission is a senior partner, then we need to be ensuring that we can demonstrate the value that pastoral care brings. We believe that it adds value to the patient's stay in our facilities, but we need to be able to demonstrate the value that this brings and how important it is really to the style of care that we provide. None of this is possible, of course, unless there's ongoing formation. In healthcare today, we're professional organisations, so we recruit leaders in with professional skills. We try to ensure that they have a values fit, but often they don't have the faith tradition to underpin the work that we're doing in healthcare. So I think with formation, there has to be a willingness to put time aside to engage in formation. I think formation can take many different paths. It doesn't have to be strictly formation for mission. It might be wound into a leadership conversation, or it might be part of the budgeting that we do with our middle managers. But somewhere in there, there has to be the notion that we're all the time trying to draw people together around the goals of Catholic healthcare. The board needs some way to help it bring the information together that it's going to need to ensure that it has mission at the forefront of its decisions. And there are some tools that can help with this. The CHA Mission Discernment Tool is one of the things that I think might be helpful to boards. CHA developed it for use for their own stewardship board, but I think they're happy to make it available to other boards as well. I know some Catholic healthcare organisations have a range of questions that they use as a filter for their decisions with their board. At Cabrini, we have a mission and business proposal. So for every business case we send to the board, we also send a mission case so that the board has both sets of data on which to base their decision. So I think there are tools and systems and processes that boards can engage in that will help them put mission as a senior partner.